Good morning, good evening, and good night to everyone from across the globe that's joining us for this edition of the EIOC Journal Club. Today, we'll be talking about the evolving paradigms, really looking at the role of immunotherapy across upper GI malignancies. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very bright, and of course, very safe United Arab Emirates. And today I'm joined by some spectacular faculty, both regionally as well as from internationally. So I'm going to let our regional speakers or faculty first introduce themselves. Farooq, maybe you want to start off by introducing yourself?
Thank you, Dr. Shaheenah. Good evening. Assalamu alaikum. Dr. Farooq Latif, consultant medical oncologist, Dubai Hospital, Dubai.
Hassan.
Hi, thank you, Dr. Shaheenah. Hassan Shahrayar. I am a consultant medical oncologist at American Hospital, Dubai, and very excited to be part of discussion today.
Amrou.
Hi, Dr. Shaheenah. Thanks for the invitation. I'm Dr. Amrou Shaban, consultant in medical oncology, Kuwait Cancer Control Center.
Alaaeldin.
Hello, and thank you for the invitation. I'm Alaaeldin Shablak, oncology consultant from Qatar. I'm trying to switch the video, but I can't. I don't know. Oh, yeah. Yeah, there you are. Yes, that's me. Yeah.
And Muhammed, Nasim.
Hi, thanks, Dr. Shaheenah, for the kind invitation. I'm Muhammed Nasim, consultant medical oncologist, Dawood Hospital, UAE.
Thank you. And it's my honor and privilege to introduce our international speaker. I have been an avid fan of Professor Eric Van Cutsem for many, many, many years. If you want to know about GI malignancies, this is the person to actually consult with. Professor Eric Van Cutsem is a full professor at the Division of Digestive Oncology at the University of Leuven and University Hospitals in Gaithersburg, Leuven, Belgium. He's a member of the Belgian Royal Academy of Medicine and president of the Belgian Foundation Against Cancer. Eric, it's such an honor and such a privilege to have you on this edition of the EIOC Journal Club. All of us are so excited to have you on board today. And you're going to give us a talk, and I'm pretty sure it's going to be spectacular, on immune checkpoint inhibition in upper GI malignancies. Where are we now? So, Eric, take it away and fascinate us with all the data that's out there for this particular malignancy.
Thank you. Thank you so much, Shaheenah, and thanks also to the organizers and the support of B1 for this session. And it's indeed a real pleasure and an honor also for me to join with you. Of course, I would have loved to be with you. This was the initial plan, but the geopolitical situation has changed the plans, and let's hope we can do that again in the future. Meeting face to face is always better than this type of meetings. Let's start maybe sharing my slides now. I think somebody else is sharing, so I cannot share because somebody else is sharing the slides.
If the technical team could help with this, please. He can't share his slides because you're sharing slides.
Doctor, we've stopped sharing, so he can share now.
Yeah, okay. Hello. Give me 1 second.
Excellent. I think it's coming up now.
Yeah, now you should see my first slide.
Yes, you need to put it on full screen. Yes, exactly. Thank you.
It's done. I think it's done. Yeah.
Yeah.
Okay. So indeed, I work. We say Leuven. Leuven is in Belgium. And what I've been asked today is to talk to you on checkpoint inhibition and in esophageal and gastric cancer, and I will do that in that order. Metastatic and locally advanced disease I will cover. And of course, since this is supported by B1, I will focus, not bias, but focus also on some of the newer data that we have seen with tislelizumab. These are my disclosures. If you talk on esophageal cancer, I will first talk on squamous cell cancer. This is, as you know, a frequent disease, less frequent than stomach cancer, the gastric adenocarcinomas. But in some regions, and especially in Asia also, it has a very high incidence and unfortunately still a very high mortality. And until recently, we didn't have a lot of treatment options. There is still unmet needs. But the good news is that we're seeing some progress in the setting, and there the checkpoint inhibitors do play an important role in some of the newer data for the management of advanced squamous cell cancer. And what I will do is take you through some of these data and explain some of the different studies that are shown here, with also a focus on tislelizumab and compare some of the data with some of the other checkpoint inhibitors and put that into perspective. And later on in the second part, I will do the same for the adenocarcinomas. This is the ESMO guidelines as it was 4 years ago. You know all this. At that moment, as you can see, there was no checkpoint inhibition. There was in the adjuvant or neoadjuvant setting, there was no checkpoint inhibition. In the advanced disease, there was no checkpoint inhibition in this scenario, and that has changed. That has changed with the first data that came through with the different checkpoint inhibitors. The first data were with nivolumab in the ATTRACTION-3 study. Later, we saw the data with pembrolizumab in KEYNOTE-181, and later on with tislelizumab in RATIONAL-302, and then later on, and I will show that also in just a moment, some of the data with some of the other checkpoint inhibitors, mainly data coming from China. There are some differences and some similarities between these different trials. These are trials in second line. The RATIONAL-302 with tisle and ATTRACTION-3 are in squamous cell cancer of the esophagus only. Pembrolizumab was a mixed population with squamous cell and adenocarcinomas. ATTRACTION-3 was Asian only. The two other studies were global studies in the setting, and they were all 3 randomized studies compared with chemotherapy. There was in the studies, all patients could be included. When we look at PDL, and I'll come back extensively on the PDL and testing and selection criteria. But there was an enrichment also, and there was an analysis also for the PDL positive patients. However, the different methodologies or the different trials at different methodologies, the NIVO study with PDL percentage positive cells, Pembro used in squamous cell cancer, PDL with a cutoff of PDL CPS 10, and the tisle studies used PDL TAP 10%. All studies were positive and showed a benefit, so consistent benefit with hazard ratios 0.69, 0.64, 0.54 for tislelizumab in this setting. So that were the 3 studies in this regard. This is the first study that our Japanese colleagues did and published now 7 years ago, ATTRACTION-3, Nivo versus chemo in pre-treated patients. This is the curve for all comers, and where there was a benefit, but the benefit was higher, and that's consistent if you look at patients with a PDL positive tumor, and that's a consistent finding. And you know, when we can discuss, and we will discuss that for sure, on the cutoff on the methodology of testing in this setting. And you know also that FDA, ODAC did some changes in their initial policies, where also they approved initially checkpoint inhibitors in upper GI cancer for all comers, and later on restricted it to the PDL positive patients in this setting. You know Pembro and Nivo since many years. Tislelizumab is the last last drug that came, let's say, as commercialized, approved and commercialized. It's a humanized IgG4 monoclonal antibody that is designed specifically and has a high affinity and binding specificity against PD-1 in this situation. And in preclinical models, this high affinity and slow dissociation rate from PD-1 has been shown, leading to a complete blockade of the PD-1 interaction in this setting, and also specifically engineered to minimize the Fc gamma receptor on the macrophages, and we know that that may play a role. This is all shown in preclinical studies, but in preclinical studies, if you look at comparative data on the left in this nice slide, you can see the red curve for tislelizumab, the other curve for orange pembrolizumab, and nivolumab, the blue curve. You can see the IC50s also being more favorable for tislelizumab compared to nivolumab and pembrolizumab in this setting. And with this also more robust T-cell activation was shown in preclinical studies. Again, in clinical studies, it's difficult to translate that, but that's clearly shown in preclinical studies. And here in this final slide to show some of the characteristics of tislelizumab and the mechanism of action, some of the points that I mentioned already are coming back. The minimal binding to Fc gamma receptor on the macrophages, the distinctive binding orientation to PD-1 in this setting, the more complete binding and blockade of PD and PD-L1, and high target affinity. And you can see some statements for the other drugs. And again, these are preclinical data. The clinical significance of all this is not completely proven in this setting, if we are honest. But at least that's always where it starts, with some interesting mechanism of action. If you look at some of the data in this setting, this is the first study, first phase 3 study, a global study, the Rationale 302, that was on one of my earlier slides. In patients with squamous cell cancer, they could be included regardless of PD status in this setting, and then there was randomization between tislelizumab every 3 weeks or paclitaxel, docetaxel, or irinotecan according to the investigator choice. 450 patients were included in the study. If you look at that, or even a bit more, that was a plan. A bit more than 500 patients were indeed randomized. In the control arm, the largest number of patients was with irinotecan, but also a considerable number of patients paclitaxel and docetaxel, and 256 patients in each arm. And this is different curves, but if you first focus on panel A, this is the survival. It's on the left top, but also I put it a bit larger in the middle. This is panel A. This is the intention to treat population, where you can see that there was a benefit with a hazard ratio of 0.7. If you look in panel B, that's the patients with a TAP positive tumor. As I mentioned already, the TAP score is being used, and I will discuss some of the data on PDL testing with TAP, CPS, and the percentage of positive cells. But you can see that hazard rate goes down in panel B with PDL TAP positive patients with a cutoff of 10%. If you look panel C on the left, there There you can see that's the TAP patients with a PDL CPS TAP score of less than 10%, where you can see that the separation is much smaller. And panel D, to be complete, is patients with an unknown scoring in this study. But as you can see, the study was clearly positive in second line with a clear survival benefit, with a hazard ratio in all comers of 0.7 and even much lower in patients with a PDL positive tumor. Looking at some of the other endpoints, response rate went up from 10 to 20%, so doubled. Response duration was clearly longer, as you can see on the right side, for tisli versus chemotherapy. There were some quality of life advantages. That's not a big surprise, but if you can show that patients live longer and live better, that's extremely relevant in this setting. Global health scores, quality of life scores, physical functioning, fatigue, advantages in some of the different parameters, as we published now some time ago in ESMO Open in this setting. This is second line. This is well known. Let's go a little bit more in depth to more recent data, the first line trials. And again, here I put the trials with Nivo, Pembro, and tislelizumab on this slide. Randomized trials in first line with chemo. Chemo backbone was sometimes different, but usually often platinum fluoropyrimidine. In the Rationale 306 study with tisli was a broader choice. I will come back to that in this setting. Some of the differences, you know for sure, Checkmate 648 with Nivo was in squamous cell cancer. Checkmate 649 was in fact a stomach cancer study, but patients with adenocarcinoma of the esophagus and of the G-junction could also be included, but adenocarcinomas of the esophagus also. Keynote 590 was a mixture of squamous and adenocarcinomas of the esophagus and the G-junction, while Rationale 306 was only squamous cell cancer of the esophagus. So some difference in this setting. The PDL testing, again, different methodologies. TPS in Checkmate 648, CPS, different cutoff in Checkmate 649 and Keynote 590, and the PDL TAP score in the Rationale 306. All different studies, all different studies showed a survival benefit. I put the hazard ratios, same range of between 0.54 and 0.7. PFS benefit, as you can see, and response rate benefit for the addition of the checkpoint inhibitor combined to chemotherapy. You've seen on many other occasions the Keynote and Checkmate studies. You may have been exposed less frequently to the Rationale study in a view of this symposium. Let's go a little bit more in detail on Rationale 306. So as you know, and as I mentioned, this is a first-line study. The chemo, what was different, the chemo choice, the backbone, the investigators had different options. Either option A, a fluoropyrimidine plus a platinum, and the platinum could be cisplatin or oxaliplatin, or option B, a platinum plus paclitaxel, and the platinum could be a cisplatin or oxaliplatin plus paclitaxel. And this was with or without tislelizumab placebo-controlled study. All comers, when we look at the PDL score, all comers could be included, but there was a further analysis looking at PDL positive patients as a secondary endpoint with a TAP score of 10% or more in the study. It was a large study. 326 and 323 patients were included. It was a global study, but 3 out of 4 of the patients came from Asia. this reflects also the global incidence of squamous cell cancer. If you look at what else is relevant, it was of course all squamous cell cancer as an inclusion criteria. There were no imbalances between the two groups, and around 1/3 of the patients, equally distributed in both arms, had a PDL TAP score of more than 10%, 15 to 20% an unknown score, and around just over 50% a TAP score of less than 10%. This gives a distribution of the chemotherapy backbone. Just over half of the patients received a platinum plus paclitaxel. 45% of the patients in each arm received a platinum plus a fluoropyrimidine, and the platinum was more often cisplatin than oxaliplatin. In my practice, we choose FOLFOX, and I will illustrate a case also with FOLFOX, but there was an equal distribution. So, and the question was really chemo, one of the standard chemo backbones plus or minus tisli in the study. This is the primary endpoint, the overall survival in all randomized patients, regardless of PDL status. And you can see that this is a big difference. In a first-line trial in squamous cell cancer, median survival went up from 10.6 months to more than 17 months, with the hazard rates of 0.66, the separation of the curves, or the overall survival rate at different time points, 6, 12, 18 months, don't need much further explanation. This curve is quite clear, and that's one of the biggest separations we have ever seen in squamous cell cancer of the esophagus. If you look a little bit more in detail to some of the data, on the left side, you can see the data for patients with a PDL score of a TAP score of more than 10%, hazard rates of 0.62. On the right side, PDL score less than 10%, which are PDL includes negative and patients with a low positive tumor, hazard rates of 0.72, and visually also the separation of the curves is more relevant on the left side with the TAP more than 10% in the setting. And these are the forest plots. You can see in all the different subgroups that there was, whether it's Asia, non-Asia, patients locally advanced, I'll come back to that, or metastatic patients, and some of the other pre-specified factors on this forest plot show that the benefit was consistent in all the different subgroups there. What else is relevant is a discussion, and this is an analysis, post-hoc analysis that we did on this study, looking at, as I mentioned initially, patients. The evaluation was done with a TAP score, but there was an analysis then further done looking at PDL CPS or tumor cell positivity with the cutoffs of CPS 10 or less, more or less than 10, PDL tumor cell more or less than 1%, and the TAP score less or more than 10%. The good news is that if you look at the overall survival and the hazard ratios, and then the interaction of p-values, is that regardless which test you used, if it's done by an experienced and adequate pathology lab, the benefit remains the same. So that was an important message in this study, and I'll come back to that. PFS, separation or clear separation of the curves with the hazard rates of 0.62 in favor of chemo plus or minus chemo plus tislelizumab versus chemo plus placebo. Investigator assessed response and externally independent validated responses were always higher for the arm with tisli. On the left side, the investigator assessed response went up from 42 to 63%. on the right side from 49 to 68%, so consistent benefit with the odds ratio of 2.3 to 2.4 in this setting, and a difference around 20%, let's say it like that. Also, the duration of response, those patients responding, the duration was clearly longer in the Tisli arm versus the placebo arm, as you can see. The safety, it's of course important to discuss. Important message is that one, we see some toxicity. The toxicity was mainly the chemotherapy-related toxicity. The good news in this regard is that Tisli does not increase a typically chemotherapy-related toxicity, and therefore there was no clear difference, for instance, in patients with grade 3 or more treatment emergent adverse event, 64%. There were a bit more patients who discontinued in the Tisli arm for, which is logic, immune-mediated adverse events in this study. But the only, let's say, difference is the immune-related adverse events, but the typically chemotherapy-related adverse events, as you can see on the right side also, is not clearly different. Just to make it a bit lighter also, and to illustrate a case that I treated, a patient who was 63-year-old when he was initially diagnosed with squamous cell cancer of the esophagus, presenting with dysphagia, mid-esophageal tumor of the mid-esophagus, clinically T3N1M0 in 2018. We proposed him chemoradiotherapy with cross. This was done in another hospital initially. And then he was operated in another hospital, complete resection of the esophagus, T3N2M0 R0. Today, we would propose patients adjuvant nivolumab according to the ESMO guidelines and different guidelines. This was 2018, so after the operation, he did not get any adjuvant treatment. In May 2020, he started losing weight and had some pain in his back. And FDG PET-CT scan showed lymph nodes, no liver metastasis, lymph nodes behind the crux of the diaphragm and between the aorta and the vena cava, and also around the aorta, clearly strongly positive on FDG PET and lymph nodes measuring a bit more than 2 centimeters, different places, quite a chain of lymph nodes. Patient came to see me and us in Leuven, and at that moment, the Rational 306 study was open. We chose FOLFOX. Patient was eligible. He signed informed consent, and he was randomized in FOLFOX plus double-blind, placebo, or tislelizumab. His first evaluation after 3 cycles, there was a partial response. We didn't do a PET at that moment, but the lymph nodes regressed clearly to sub-centimetric measurements, so clearly much smaller. Tolerance was okay. After 8 cycles, after initial dose reduction, after 6 or 7 cycles of oxaliplatin, after 8 cycles, we stopped because polyneuropathy grade 2. The lymph nodes were PET negative at that moment on the CT, but you could still visualize some lymph nodes, but all below 1 centimeter. So if we would do that in a normal situation without the previous scan, we would not be sure that there was a tumor relapse at that moment. Patient continued with 5-FU, placebo, or tislelizumab for 15 months because of good tolerance and because he was very motivated. Became active again. He gained a little bit of weight again. And then after 15 months, he stopped 5-FU because at that moment, diarrhea and fatigue increased and continued with placebo or tisli. And then in April 2022, so this is As you can see, he started in May 20, almost 2 years. There was an unblinding because analysis was done of the study, and he was in the Tisli arm. He didn't have any immune-related adverse event. He wanted to continue, although we were not sure that there was still remaining disease. He continued until April 2024. At that moment, he stopped the treatment. And yeah, probably I mentioned here partial complete / complete response because you could still visualize the lymph nodes, not measurable anymore, no metabolic activity. And at that moment, we stopped also because the trial stopped and we didn't see the additional value of continuing out of protocol with the checkpoint inhibitor. Since that moment, until now, last month, he's doing fine, no symptoms, no pain. He would have cold, he would have new symptoms, and he had sequential CT scans, which probably show a complete response. So this is now almost 6 years after the diagnosis of relapse. So that's a real case. I didn't make it up. That's a real patient in this setting. Further analysis of this 306 study, that's a presentation that we gave with the group last year at ESMO GI. Manuscript is not yet out, it's submitted. This was a subgroup analysis of the 306 for patients with locally advanced disease who were not candidates for operation, not candidates for radiotherapy. And then in this trial, they could be included, and there was a randomization between chemo placebo or chemo tislelizumab in this setting. And there were around 49 and 39 patients in each of the two groups, so 88 patients in total. Characteristics of this locally advanced disease and the ITT population were similar. When we look at the parameters that are mentioned here, of course, they had no metastasis. That's the definition of this subgroup analysis. Looking at the results, at the data, because that's the first time that this is in a randomized study in this regard. You can see here the survival for all comers, clear separation of the curves, hazard rates of 0.49, despite the low numbers, statistically significant values. And if you look at the patients here with a PDL TAP score of 5% or more in this analysis, the overall survival also clear separation of the curves. Numbers are very small in the setting, but it's indicative of a benefit also in this group of patients. This is the PFS for patients with a TAP score of more than 5%. You see the separation of the curves. The tumor response went up on the left side, the overall response rate by the investigator, and on the right side, the time to response. If you look at the tumor response, that went clearly up in blue for patients with Tisli, in gray for patients with placebo plus chemo. You can see the clear differences in this study. That's the duration of response for those patients. Having a response, numbers are low, but and that's for the TAP positive patients with a cutoff of 5%. That's just to illustrate always the curves in this setting. And just to end with squamous cell cancer of the esophagus, to put everything together again, I've shown you the rationale, the keynote, the checkmate studies. There are different studies from China also with other checkpoint inhibitors, sintilimab, camrelizumab, serplulimab, toripilimab, different data sets in this setting. There are some differences in the trials, but and this is the analysis for squamous cell cancer, all comers, and the PDL positive patients. In this exercise, you can see that the different checkpoint inhibitors have activity, so consistent data in this setting. And with that, we can say we can integrate this. This is a personal interpretation. The new updated ESMO guidelines are not yet out, but that's where we are today. shown you in the beginning slide of 2022. In the adjuvant setting, I did not discuss, I mentioned it, after cross chemoradiotherapy, followed by surgery, even R0 resection and still residual disease, nivolumab for 1 year is standard. In metastatic disease, I think we have different options. Pembrolizumab plus chemo, nivolumab plus chemo, or tislelizumab plus chemo, different testing methodologies. I will come back to the adenocarcinomas when I discuss the stomach cancer, but also there, different options can be integrated in this setting. And then for those patients who, for one or another reason, are not exposed to a checkpoint inhibitor in first line, second line, nivo, tisli, I put pembro a little bit smaller because it's not approved, at least not by EMA in this situation. Let's go to the data in stomach cancer, even more frequent, as you know, more than 1 million new patients a year. High incident tumor, one of the most frequent tumors and one of the most frequent causes of cancer-related mortality. And also in your region, very high incidence, as you all know, in this setting. Again, let's do the same exercise, go through the different trials, and of course, focus a little bit on the newer trials with tislelizumab. This is the rationale 305. That's how the study in gastric and G-junction adenocarcinomas is included. It's a chemo doublet, 5-FU cisplatin, or Capox, Xilox, plus or minus tislelizumab. The primary endpoint was the overall survival in PDL positive patients with a TAP score of 5%. In this study, however, all patients could be included regardless of the PDL score in this data set, in this study. Almost 1,000 patients were included, no imbalances between the two studies. It was a global study. Again, here, 3 out of 4 patients come from Asia, reflecting also the higher incidence in Asia, as you know. 8 out of 10 patients, 80% were stomach cancers, 20% G-junction tumors. There were patients with quite a lot of patients with peritoneal disease, and a little bit more than half of the patients had a PDL score, a TAP score of more than 5%, for around 45%, less than 5%. And there were more patients clearly with Capox than with 5-FU cisplatin, but again, no imbalances between the two groups. If you look at the overall survival, the intention to treat on the right side, the PDL positive with a TAP cutoff of 5%. On the left side, you can see a clear benefit, almost 5 months benefit in the TAP positive patients for median survival going up from 12.6 to 17.2 months with a hazard ratio of 0.74 in this set. For patients with a PDL TAP less than 5%, the hazard ratio was not statistically significant. So 0.92. The curve is not shown here in this on this slide. Here you see, and that's a full slide, but that's forest plots for survival. You can see it's always on the left side of the vertical one line, so indicating that the overall survival benefit is observed across the multiple patient subgroups in this setting, as you can see and as you can reappreciate if you wish to do that in the publication or in the slides. Progression-free survival was better. Tumor response went up in gastric cancer, as you can see on the two curves here on this slide. So higher overall response, longer PFS, more durable responses also in this study. And again, here the same message. The safety profile was manageable. say everything is manageable, but it was clearly manageable. Of course, more immune-related adverse events in the TISLI arm compared to the placebo arm, and a bit more treatment related adverse events leading to treatment discontinuation in the TISLI arm. You had another drug in this setting, but chemotherapy-related adverse events, which are the most important, were not higher in the placebo compared to the TISLI arm in this setting. So this study is clearly positive and shows a clear benefit in this setting. Let's go a little bit more in detail then to some of the data and compare. And of course, we can never do cross-trial comparisons, but highlight some of the data of the other studies. Historically, the Keynote 649 was the first one. 1,500 patients, a checkmate for 649, Keynote 859, 1,500 patients, K-Pox, FOLFOX as backbone. You can see hazard ratios very similar, 0.79, 78, 0.8, PFS benefit, over response rate benefit, and you can see some of the data with the different in the PDL subgroups, which are more favorable hazard ratios with different methodologies. In Checkmate 649, PDL CPS cutoff 5. In the 859 study, there was an analysis for PDL CPS 1 and 10. And in the Rationale 305 study, the TAP score of 5% was used as cutoff in the setting. And that's what you can see here, where I put the different survival curves in these different studies. Nivo, TISLI, Pembro on the right side in this, where you can see always separation of the curves and a persistent separation. It's not that the curves come together at a later time point, but that's consistent in the different trials. I promised, and I did already, I promised to come back on some of the biomarker data. This is a presentation given by Marcus Müller. Sorry. At ESMO GI 2 years ago, almost now, where there was an analysis in this almost 1,000 patients looking at the TAP score and at the CPS score, looking at the distribution with the different cutoffs of TAP and CPS, and with as goal to see, to look at the consistency between TAP and CPS scores. Because as you know, TAP scores for the pathologists in GI cancer, they were used to do more frequently CPS scores. But in fact, the CPS scoring is more time consuming than TAP score. Pathologists, if they know the methodology of the different scoring methods, they prefer to do TAP score because it takes less time. They have to count less in this setting. This is the visual representation for TAP with different cutoffs, 1% less and more than 1%, 5 and 10, and CPS score of 1, 5, and 10. And if you look carefully at the hazard ratios, whether you look at the numbers on the right side or in the middle at the vertical bar, you can see that that it's quite consistent data. And the higher the TAP or CPS score is, the lower the hazard ratio is, or the bigger the benefit is as a bottom line message. And that's shown again on the same way. If you want to see that visually, not spend too much time on showing the slide, but visually you can see that on the right side, TAP more than 10%, CPS more than 10, the separation of the curves is bigger than on the left side, but the separation of the curves in TAP and CPS looks quite similar if you look at the upper panels and the lower panels in this setting. And the same is for the PFS. But then they did also, the group did also an analysis on, let's say, really to look at the concordance with statistical analysis. And here you can see that there was a good concordance. Different statistical methods have been used. I don't have time to go in detail, but the message is that in TAP score 1% and CPS 1, very, very high concordance, very good concordance in 5% or CPS 5, and good concordance also on the right side with a cutoff of 10% or a score of 10 in this situation. So the bottom line message is that probably they are quite, maybe I should delete the word probably, but they are quite interchangeable in this situation. And both, in fact, in theory, we can use both TAP and CPS for the selection of patients with this lizimab. A final data set, I cannot refrain of showing you some of these recent data. Some of you may have seen them. These were the data presented for the first time earlier this year at ASCO GI, the Horizon GA01 study. There will be updates at ASCO and ESMO GI. And this was a study in HER2 positive patients. Classic criteria, HER2 positive immunochemistry 3+ or 2+, and a positive ISH test, where the standard was long time chemo plus trastuzumab, where now with the Keynote 811 study, the standard has become chemo plus trastuzumab and pembrolizumab. And this study looked at a new bispecific antibody zanidatamab, which is a bispecific antibody targeting 2 different epitopes on the HER2 receptor. In fact, the same epitopes as trastuzumab and pertuzumab. And then there was an arm chemo plus zanidatamab and an arm chemo plus tislelizumab plus zanidatamab based on the Keynote 811 study where chemo, trastuzumab and pembrolizumab showed a benefit over chemo trastuzumab in this setting. So that's the design of the study. Patients had to be HER2 positive, as I mentioned, adenocarcinoma of the G junction or of the stomach, and could be included regardless of PDL status in this study. There were 2 primary endpoints, PFS and OS. This is the PFS for the comparison of chemo trastuzumab, the lower curve, the gray curve, or chemo zanidatamab plus tislelizumab. You can see a PFS difference going up from 8 months to 12.4 months, hazard rates of 0.63. This is trastuzumab chemo versus trastuzumab zanidatamab without tislelizumab. Also a benefit in PFS. This is the PFS in pre-specified subgroups. Don't want to spend too much time on that, but you can see that as well in the arm zanidatamab tisli as in zanidatamab alone, there was a PFS benefit in the different subgroups compared to trastuzumab chemo. What is even more relevant and more spectacular is the overall survival. And this is trastuzumab chemo versus zanidatamab tisli chemo. You can see median survivals of more than 2 years, 26 months, more than 7 months benefit in median survival when trastuzumab is replaced with zanidatamab and combined with tislelizumab. You see the clear separation and the persistent separation of the curves, highly significant values. Forest plots in this setting. This is the overall survival for the arm without tisli. This is p-value of 0.056. there was a trend in survival benefit in patients treated with zanidatamab plus chemo versus trastuzumab chemo, but this trend, 5 months difference, was not statistically significant. We have to see longer survival times and longer survival follow-up in the study to have a final answer on that, but that's the data as they are until now. Overall response rate, no big differences. 70% in zanidatamab tisli, 69% or 71 and 70%, if you want to be precise, in zanidatamab chemo and 66 in chemo. But the big difference is much longer duration of response, 8 months, 14 months, and 20.7 months in zanidatamab tisli chemotherapy. There is, I wouldn't say an issue, but there is clearly, we need to be aware of the clearly more frequent and clearly higher incidence of diarrhea in the combination of zanidatamab tisli plus chemo in this study, as you can see, and the recommendation is today to treat patients with prophylactic loperamide. And there is one important point I forgot to mention. I can show this here, for instance, that's looking at the PDL status on the bottom of the slide in a TAP negative patients and TAP positive with the cutoff here of 1%. There was benefit in both groups. I remember in the Keynote 811 study, patients with a PDL negative score did not have any benefit from chemo, trastuzumab, pembrolizumab. Here with chemo, tisli, zanidatamab, in the PDL negative patients subgroups, numbers become smaller, there is a benefit. We don't have a good explanation, but maybe if the immune environment is changed with this bispecific antibody. That's not completely clear in this setting. Coming back to the diarrhea, I mentioned already mandatory diarrhea prophylaxis is needed in patients in the zanidatamab containing regimens, and with that it becomes manageable. The trial was done with Kpox. We will use, based on the phase 2 study, also FOLFOX in this setting. It's, let's be clear, it's not yet approved, the agent. We expect with these data the approval of the combination of zanidatamab plus tislelizumab and chemotherapy for this group of patients. And that's what I wanted to share with you before the discussion, just very data-driven. Just one slide, or 2 more slides. Leuven, for those who don't know that, is a small city, 100,000 inhabitants, just east of Brussels. Our university celebrated last year the 600th anniversary, 64,000 students, and on the different rankings, innovation, times, Shanghai ranking, we are high ranked innovation, number 7 in the world, number 1 in Europe. We have one of the biggest chip research centra in Europe, in the world, even IMEC, and the largest beer brewery in the world, in our small city, where you can see on the left the hospital. Right up is the city hall and then some of the colleges of the university, and just with an open invitation for ESMO GI in Munich. Not in Barcelona this year, in Munich, because of the Tour de France, which occupies the whole city of Barcelona for 2 days at the same dates. If you cannot attend in presence, you can attend virtually also to ESMO GI. Thanks for the attention and happy to continue the discussion.
Thank you, Eric. That was a whirlwind of very, very valuable information. I have a number of questions. In case anybody else has some questions, please feel free to ask Eric. This is your opportunity before I go into the panel discussion. Eric, I'd like to ask a couple of questions. First is in the esophageal, second in the gastric. Do we really need to test for PD-L1, whatever the methodology, to give immunotherapy? Because even if you see the FDA approvals, they've been all over the place. FDA approval for Nivo is irrespective. NCCN guidelines say no, you need to do PDL scoring. And it's the same with the other immune checkpoint inhibitors as well. Now you've got tezepelumab. When I look at the data, I see a benefit in the overall cohort as well. So can you first please just sort of tease out what we should do practically in the community? It doesn't matter the method with which you test. The question is, do you need to test for gastric and esophageal carcinomas in order to use immunotherapy? A question that all oncologists are trying to ask.
Yeah, my answer is yes. And initially, indeed, as you said rightly, the FDA approved Nivo for all comers, but the ODAC is asked and is made to change the FDA. So today it's not approved anymore for all comers, metastatic disease. It's only for PDL positive, regardless of the different methodologies, and you can discuss some of the cutoff criteria. In esophageal cancer, the correlation is stronger in squamous cell cancer than it is in gastric cancer, but it's quite consistent, and it's not a perfect biomarker, but it's consistent that the more positive the tumor is for PDL, the higher the chances of benefit. So yes, the answer is yes. Of course, the all-comer analysis, I wouldn't say they are biased, but they are a bit screwed with the fact that if you look in the all-comers, there were in this group, there is a big weight also from patients with a PDL positive tumor. To answer your question, you should look in the patients with really a PDL negative tumor. And I mentioned one of the data, one of the figures there in the PDL negative tumors, really negative, there was no benefit. So yes, I would say we have to test that. That's also the position of EMA. That's the position now of FDA, and that's the position not only of the approval authorities, but also the scientifically sound proposal and in the different guidelines. The two exceptions, maybe, but I didn't discuss that, is in the adjuvant setting after cross surgery and Nivo. There, it's all comers. Although more recent subgroup analysis, but this trial was done before really we were so much into this biomarker. If you look at there is in the subgroups, there is a bit bigger benefit, more benefit in the PDL positive patients also in this setting. And the big difference, maybe the last one that I've shown, the Horizon GA01 with zanidatamab, and I gave you a hint, I don't have a complete explanation, is that the immune environment may be changed. So as far as we can understand the data in this setting, but that's not yet approved, as I said, zanidatamab, there the story may be different. But let's say in the straightforward chemo plus or minus checkpoint inhibitor in squamous, in adenocarcinomas, in metastatic disease, first line, yes, we have to test, I think.
If I may ask the question for the Horizon study, I mean, I felt it was a little bit unfair to have an arm. You had an arm with trastuzumab plus chemo, zani plus chemo, zani tesi plus chemo. Why was there no arm of tesi plus trastuzumab plus chemotherapy? Would that not have been a better design?
So Tisli trastuzumab.
Yes, plus chemo, of course.
Yeah, then you come up with 4-arm trials. 3-arm trials are already extremely complex, and in this 3-arm trial, there is no formal comparison between chemo zanidatamab or chemo zanidatamab tisli, because the sample size would even have to increase much more. So adding a 4th arm would be extremely difficult. And yeah, this was a study sponsored by Jazz Pharmaceuticals. They don't have any, let's say, benefit. They don't have any reasons to design an arm chemo tisli plus trastuzumab. So their goal was to get approval for zanidatamab in this setting, and that's why these two arms were chosen.
Okay. Does anyone have any?
And the antibody, as I mentioned, has clear advantages. It's a bispecific antibody. We have seen now in HER2 also the Chinese bispecific antibody, sorry, I have to exercise for the pronunciation, but the bispecific antibody published very recently in the Annals of Oncology in second line. So bispecifics, in theory, preclinically, are more promising than trastuzumab. Yeah, and that's how the trial was done with all this rationale.
Oh, yes, please go ahead.
Yes, thanks, Dr. Shaheen. I'm Dr. Shaban from Kuwait. Thanks, Dr. Eric. Very interesting talk. I have a couple of questions. And first of all, regarding all the trials presented for the immune checkpoint inhibitors for the esophageal and the gastric cancer, there is difficulty to compare trials among us, but roughly the benefit we get from the immune therapy as a general is in something in terms between 2 and 3 months. Likely, the benefit we get is equal between the 3 competitors now, the Pembro, Nivo, and the Tislelizumab. I'd like to hear from you, Dr. Eric, if you have a special preference for certain immune therapy, and based on what? It looks like the Tesla have some greater affinity. And also now in the era of the Claudin, when it comes to first-line treatment selection, sometimes it's confusing now where to start first. Start with the targeted monoclonal therapy if I have a case with Claudin 18 positive, start first with zolbetuximab, or start with immune therapy, then when to arrange the treatment sequence.
Yeah, that's two very good, completely different questions. The first question is regarding which checkpoint inhibitor, and I've discussed mainly the 3 that are available, but you could add 3 or 4 other, probably more Chinese PD antibodies, and indeed there was never a head-to-head comparison. We don't have this data to see, and which one is really the best in clinical setting. This will never be done because we have more interesting data and studies to do. We will not make progress with a comparative study, chemo Nivo versus chemo Pembro, or chemo Nivo versus chemo Tisli. This setting, that's going to be probably in the non-inferiority trials, and that's going to we'll lose too much money. It's better to invest that in real innovation. So that's the first statement in this setting. 2, I've shown you in the beginning some of the preclinical data of Tisli, Nivo, Pembro, and mechanistic data. Yeah, I clearly said also that this is preclinically in cell lines, and in cell lines and preclinical models does not all, if we see some advantages, that does not always translate in clinical benefit. That's completely correct. But yeah, as an oncologist, we feel always more comfortable if we don't have head-to-head studies, and then we can choose between different drugs, and one of them, at least preclinically, has a better advantage, better activity. There was a network meta-analysis also showing this. That's not a really comparative analysis, but that's a network analysis looking at the different data, which speak in favor of Tisli in this setting. And then, yeah, in times, maybe in your countries, resources are or were unlimited. In our country, economic aspects do play a role also in this setting, and then it comes up to the price also that may be a selection parameter in this setting, but that's then more up to the companies to explain that this structure. But so this may also be relevant. But if you look at all this, there are clearly arguments to go for Tisli in this setting. If somebody says I will go for Pembrol and Nivo, I will not say that that's a wrong choice. I never said that, and I will not say that. And then in some regions, another selection parameter maybe, and that's why I explained the data on the different scoring methodologies. Some pathologists will report initially only PDL-CPS, and then the clinician doesn't know what it means. What we see now more and more is that the pathologists start to report PDL, CPS, and the TAP score, and then the clinician can choose. That's the ideal scenario, because in some regions, not everywhere, but in some regions, you have to stick really to the label. And then if a pathologist reports only TAP, then you can, in theory, only use Tisli. If the pathologist reports CPS, you can use only Pembrol, for instance, in this setting, or Nivo. Yeah, they are interchangeable, these different methodologies, and that's what I wanted to say also in this setting. So it's a long answer to your question in this setting, that there are some arguments in the choice and selection. And the second question, I was speaking too long on the first question. What was the second question again?
That's fine. We will be covering that actually in the panel discussion. Because we have only like 20 minutes for the panel discussion, and I really wanted to get questions. So just going back to the Rationale 305 trial, you can see, and you presented this really well, Eric, in which they looked at the PDL1 subgroup biomarker analysis, and you can see, as you mentioned, as the TAP score increased, the benefit actually increased. But they also did a CPS score, and as that increased, you can see the benefit is actually increased. So the first question to the panelists is that we now have multiple IO chemo combinations approved for that first-line gastric GE junction cancer, and now with around a 17-month overall survival that's been reported from the Rationale 305. When you look at the totality of the evidence for all the available immune checkpoint inhibitors that we have actually approved, is this a class effect, or are there really meaningful differentiators between these agents? And Hassan Shahrayar, maybe you can try and take a stab at this question. I think Eric, to a certain extent, has actually already answered it. But what are your thoughts here, Hassan?
Yeah, so obviously my experience is limited to Nivo and Pembro. I haven't used Tesli in my clinical practice yet, but just looking at the data and in a overview fashion, to me it seems all very similar. I think their hazard ratios for OS is also in the same ballpark range. Their safety profile is not very different. There might be some subgroups where there might be some advantage, but again, I think these are more exploratory analysis. So I'm still, I think, at this point confused, really, like how do I really choose among the three? To me, it sounds like they are all PD-1 inhibitors, and by and large, they have similar efficacy.
All right, and Eric, what are your thoughts over here? Is there anything that you think could be differentiating these agents?
No, as I said, there are a lot of similarities. Some of the preclinical factors that I mentioned are relevant. The design of the study, if you have to stick to the label, and then the pharmacoeconomic aspect can be a differentiator also.
Okay, we'll come to that in a minute. So let's look at the overall survival subgroup analysis in patients with and without peritoneal metastases in the Rationale 305 trial. And you can see in patients without peritoneal metastases, the median overall survival improved from 14 months to 17.3 months, associated with a hazard ratio of 0.79. But interestingly, when you looked at the patients who had peritoneal metastases, you're also seeing an improvement in that overall survival hazard ratio 0.78, very similar to what we're seeing in patients without peritoneal metastases. And you can see this considering the group of patients who are getting tislelizumab plus chemotherapy. Now, we haven't really seen this data in terms of that stratification by presence or absence of peritoneal metastases in some of the other immune checkpoint inhibitor trials. Now, looking at this and knowing that the presence of peritoneal metastases is inherently associated to be a poor prognostic factor in patients with gastric cancer, in your clinical practice, do you feel the current evidence actually addresses this group adequately, Farooq?
Okay, Shaheenah, yes. I think obviously the patients with peritoneal metastasis have poor prognosis. It's a difficult to treat group of patients. The data we have so far before tislelizumab, I think both the Nivo and Pembro studies, they included about 20% of patient population who had peritoneal metastasis, but we don't have a separate data in terms of efficacy in that group of patients. The current study, which was presented with the tislelizumab, around 40% patients had peritoneal metastasis. So you have a larger group of patients with peritoneal disease, and we've seen the data in terms of favorable hazard ratio, both with or without peritoneal metastasis. So I think current evidence now emerging, it does address this subgroup. Probably not adequately, but the evidence is there now. So if I had to choose between the combination, I think the data with tisle is more stronger, in my opinion, as compared to other two immunotherapy, immune checkpoint inhibitors we have.
Eric, what are your thoughts over here regarding this?
Yeah, this is the first study where it was done. It's relevant. Peritoneal metastasis, so I just echo what was said, is a poor prognostic factor, but even in patients with a worse prognosis, they benefit from the addition of tisle. So I don't think we can exclude patients, even with a worse prognosis, at least if they are in good condition, from tisle in this setting.
Okay, so let's go on to actually a very, very interesting question, which you have actually touched upon, Eric. Know that in the TESI trials, they use the TAP score for determining PD-L1 status, but we also know that all the other immune checkpoint inhibitor trials have so many different methodologies. We're typically used to the CPS score, and you can see from the data from the Rationale 305 study, looking at the PD-L1 biomarker analysis, there's a lot of overlap between the two methodologies. Now, I think one of the things that community oncologists are going to ask the question, and I'm certainly a community oncologist, and I'm going to ask the question, do we really need to do another methodology for testing for PD-L1 in the clinic to be able to use TESI? We already have like 1,000 different ones that we need to test. This is adding another layer to an already overworked pathology department. But what I'm seeing over here is there's good overlap. So I'm going to go to, who should I pick on next? Alaaeldin, maybe I can ask you, if you have a patient and you want to use tislelizumab, are you happy using the CPS score to be able to determine who should be, whether or not to use tislelizumab?
Right. Okay. Well, I think the data that was presented today were compelling. That there is a lot of similarity between both techniques in terms of the prediction value for efficacy of tislelizumab, and I'm happy to use the CPS for a simple reason, which is my pathologist will only give me CPS. They will not test with TAP scoring for GI, which is the main thing in pathology. Now, I know that Prof. Van Cutsem mentioned that the pathologist may be trained to use the CPS, and I don't know really how difficult or easy this is for them to be retrained to use the CPS in the GI cancer. So I would be using the CPS score, but I think all these data maybe one thing that we need to focus on and discuss is really PD-L1 the best marker we have to select patients for immunotherapy? I mean, this is one of the biggest questions, whether it is TAB or CPS. PD-L1 itself, can we reliably use the PD-L1 to select patients? Because we know those patients who are positive, they still don't respond, and those who are negative, they may still respond. So regardless of techniques, and I think now we have we have those. We have to stick to one of them. But the big question in my mind, I think, is shall we try to find other markers that will help us to select patients for IO apart from PD-L1? And I don't know what the panel feels about that.
Well, I'd like to actually go to Eric and actually ask him the question, because as community oncologists, we've all been asking the same question. One, is PD-L1 the best biomarker? And two, why on earth do we have so many methodologies to test for PD-L1 in the clinic? And three, can we just use, like Alaaeldin says, his pathologist is only going to test for CPS. They're not going to do anything else. So can we just use that for all the immune checkpoint inhibitors, and here specifically for TESI?
There are many questions in that. First of all, indeed, pathologists started with PDL-CPS methodology. They can do TAP. TAP is of course, with everything, there is a small learning curve, but TAP is easier than CPS. It's much less time consuming. It's much easier. I'm not a pathologist myself, but if you look in all the data, in all the studies, if you talk with a lot of pathologists, it's easier in this setting. Your question, one of your questions was also, would you be comfortable with using TISLI with the CPS if you've only this report? Scientifically, the answer is yes, clearly yes, and it's possible in some regions. I don't know about your region. In Europe, EMA has approved it for TAP score. Some countries in Europe will be more rigid on that for reimbursement and will say, no, you need to document the TAP score if the regulators are not aware of all this scientific data in this regard. But scientifically, you could interchange them in this setting. Is PDL the best? No, MSI is probably an even better marker, but that's only 3-4% of the patients which are MSI high or deficient mismatch repair. But PDL is the best marker that we do have. Is it a perfect marker? Far from. No, it's not a perfect marker, but it's the best what we do have in this setting. And can discuss different cutoffs. That's dynamic progress in knowledge, how the cutoffs and how the methodologies were integrated in the trial. One thing is clear, is that the PDL negative, really negative tumors, by experienced pathologists, they probably don't have benefits from the checkpoint inhibitors in this setting. And then there was a question, indeed, there is overlap between Claudin, between the different biomarkers. And if I see a patient with gastric cancer, I want to have 4 biomarkers. That's MSI high, deficient mismatch repair. I want to know the HER2 status. I want to know PDL status, and our pathologists report now CPS and TAP, and I want to know Claudin. There is overlap between different biomarkers, and let's say clinically most relevant discussion point today is the overlap between PDL and Claudin. And your question inherent to that is, what do we do in a patient who is PDL positive and Claudin positive? If the patient, for me, is PDL positive with a CPS score or a TAP score up to 5, between 1 and 5, and strong Claudin positive, I would treat the patient with zolbetuximab. If the patient is strong positive for both, I would prefer, would be more comfortable with a checkpoint inhibitor today, as far as today is concerned. You may have seen that at ASCO GI, there was a presentation of a non-randomized study combining checkpoint inhibitor plus zolbetuximab in Claudin positive patients, and then a subgroup analysis of PDL positive and negative patients. it was phase 2, non-randomized, but the results were quite spectacular in patients who were treated with chemo doublet, zolbetuximab, and a checkpoint inhibitor if they were Claudin and PDL positive in this setting. There is a randomized phase 3 study ongoing in this group of patients, Claudin positive and PDL positive, to treat them with chemo checkpoint inhibition plus or minus zolbetuximab. That's the Lucerna study, sorry, the phase 2 is Illustro and the other is the Lucerna study. That study is recruiting extremely fast right now. So that's what we do know. HER2 also overlaps with some of the other biomarkers, and Koishitara from Japan, it's a very large series, has been looking into that, but HER2 and PDL discuss some of these topics. I've shown you the data on zanidatamab checkpoint inhibition. I mentioned to you the data on Pembro, trastuzumab. There also, we don't have data whether Claudin positive and HER2 positive, there is some overlap also, but traditionally the zolbetuximab was treated only for HER2 negative. That was the inclusion criteria.
Okay.
So that's, in a summary, in a few minutes, everything we know. And maybe not everything, but some of the facts we know.
Mohammed, in Tawam Hospital, I'm pretty sure you're also doing the CPS score over there. If tesiluzumab becomes available, will you be comfortable using Tesi based on the CPS scoring system and based on the data I've just shown you that looks at very good concordance between TAP and CPS?
Yes, of course. As we've seen from the data there, it's very good concordance and they are quite interchangeable. And benefit was seen across the different expressions of TAP score and the CPS score. So I'll be comfortable using based on the CPS score. And certainly with the unique mechanism of action we've seen and the longest survival benefit from tesiluzumab. So certainly this will be exciting to use this in the first line setting in this group of patients, particularly as you've nicely shown. The ones with the peritoneal metastasis, we very commonly see patients with peritoneal metastasis, and those are the ones which have worse prognosis. And we've seen benefit across the peritoneal, the ones with the peritoneal metastasis as well. So certainly I would be comfortable using tislelizumab based on CPS score as well.
So, I mean, Eric, if I may ask the question before we go into the next question, the case that you presented was absolutely spectacular. Of the young man with esophageal carcinoma who's now 6 years out and finished his TESI. I may have missed it, but what was the TAP score for that patient?
Well, in the study, it was not mandatory to know at the moment of randomization. There was an analysis afterwards, but it was more than 10%.
It was more than 10%. All right, so we have a network meta-analysis that looks at the relative efficacy and safety of different immune checkpoint inhibitors, including nivo chemo, pembro chemo, and of course tesi chemo, in the treatment of first-line gastric cancers and gastroesophageal carcinomas. And you can see that when you're comparing nivo plus pembro, it's almost the same in terms of overall survival. When you look, I'm sorry, my thing seems to be going on its own right now. And then, of course, when you're comparing on this side of the chart here, I'm just going to show my arrow over here. It favors Tesi plus chemo, and here it favors the comparator arm. And you can see that those hazard ratios are very, very similar when you're looking at overall survival and progression-free survival, suggesting that Tesi chemo, in terms of efficacy, is similar. Although this is not a head-to-head comparison, this is a meta-analysis. It looks very similar to nivo chemo, pembro chemo. But when you're looking at the safety, you can see that it actually favors Tesi plus chemotherapy. Eric, how do you explain this in terms of why is the safety looking better for Tesi chemo versus nivo chemo or pembro chemo?
I don't have a good explanation. The data are the data. mechanistically, with some of the differences, I focused on some of the mechanistic and design differences in this setting, which are more arguments in favor of preclinically superior activity. I don't have a good explanation why this is, but the data are the data. Is that the design, the drug, that it's more specific binder to the in this setting, maybe, but yeah, nobody knows. But that's what the data show.
And Dr. Amrou, what are your thoughts over here? Does this make a difference to your clinical practice? The fact that, I mean, we don't have a clear-cut explanation, but it's showing that Tesi chemo has a better safety profile compared to Pembro chemo and Nivo chemo. Does this impact how you choose your therapy in the clinic?
Yes. As Professor Eric mentioned, still, this is the data. We have no clear explanation, but personally, I have an interest to use the Tesla, my clinic. I to build this experience, especially now we have good experience with the Nivo and the Bembro. And if there is some data suggests that there is another competitor with good safety profile, may I go for this.
Okay, Farooq, what are your thoughts here? You're muted, Farooq.
I think I would agree that the different parameters I look at before deciding about a particular drug is obviously first is the efficacy. We've seen that all three immune checkpoint inhibitors have more or less similar efficacy in these group of patients. And the next step will be to look at the safety profile. And obviously, you want to retain your patient and you want to make sure you don't have to dose reduce. So if a drug particularly has a better safety profile, I would favor that drug. And I think the next will be availability and of course the cost, which we haven't discussed yet. But yes, if safety profile is better, that will help me decide which ICI I will use.
Okay, so now coming to the overall survival in first-line esophageal squamous cell, you can see the rationale. 306, looking at that 3-year update, there was a clinically meaningful improvement in overall survival for Tesi plus for Tesi plus chemotherapy, and you can see that the hazard ratio for overall survival with Tesi was compared to chemotherapy alone was 0.7. The 36-month overall survival rate was 22.1% versus 14.1% in those patients who were getting placebo plus chemotherapy. So the question here is, moving into the realm of esophageal squamous cell carcinomas, immunotherapy has fundamentally changed the treatment paradigm. Can you comment on the evolving evidence? Farooq, maybe we'll go back to you, and then Hassan, you tell us what you think about the evolving evidence for IO plus chemo combos in those patients with first-line squamous cell carcinomas of the esophagus, and does this really apply to your practice? You're muted again, Farooq.
I think obviously things have evolved over the last few years in terms of integration of immune checkpoint inhibitors in esophageal cancer. Especially if you look at the squamous cell histology, we have 3 immune checkpoint inhibitors available: Nivo, Pembro, and Tesi, and all has almost comparable efficacy. So I don't really have access to Tesi at this point. So currently we have Nivo and Pembro, and that is what I use in my clinical practice. Yeah.
Hassan?
Yeah, I think agree.
Again, we can't hear you, Hassan.
Can you hear me now? Hello. Can you hear me?
Yes.
Yes.
Okay, so no, I think immunotherapy has fundamentally changed the treatment paradigm in upper GI cancers, and I would consider it now part of our standard of care along with chemotherapy in advanced setting. And esophageal squamous is no exception to that. We have seen data in the adjuvant setting earlier as well, but I think now we have several IO combinations in the metastatic, all pointing towards that there is a benefit to addition of immunotherapy. So I would consider it standard of care to offer IO chemo combination in this setting. Yeah.
Eric, what are your thoughts here?
Yeah, I think I expressed my thoughts already, but yeah, there is a clear change. It's before checkpoint inhibition, the outcome of patients was poor. It's not yet very good, but it has improved, and it's a first important step. And I think it becomes standard of care within the criteria that I explained.
So in the last minute, the multi-million-dollar question, if we had Tessie available in our clinics tomorrow, where would you position it in your treatment algorithm in the upper GI cancers? And further, would price make a difference? I'm going to go through all of you, and then I'm going to let Eric have the last word. Hassan, what are your thoughts here? Very quickly, because we've got like 1 minute.
Right. So I'm very excited to use Tesla because I think it has shown very good data. I think at least it's comparable. I think the preclinical data is quite intriguing. Maybe it has a better safety profile. Maybe it's a better option for the peritoneal subset. So I think I would definitely use it. And if the cost is also better than all, I think it's additional plus. Of course, we're looking for anything that is better than what's the existing options are. So yeah, I'm very excited by the promising data presented today.
Farooq?
Agree 100%. No extra comments really. Yes, if it's available, I will be happy to use it. And obviously, price does make difference in my practice.
I think both price and safety makes a difference in my practice, but
Yeah.
what are your thoughts here?
The same as my colleagues, especially with the case that presented by Prof. Eric, with an immune therapy used for more than 4 years, controlling likely this is a safe one. Interesting to use. Price is important, especially more than 2/3 of our patients is non-citizens, and if we have patient help programs that can, with affordable drug price, this is definitely one of the important factors to go for this.
Muhammed?
Yes, certainly agree, with the very exciting and promising data of teslelizumab, very comparable to the other IO and chemo combinations, and better safety profile, quite exciting, good results in patients, subset of peritoneal met patients as well. And on top of that, if cost was in favor of teslelizumab, I'll certainly be using it as first line.
Alaaeldin?
Yeah, nothing to add. I agree to
All
all
right.
that's been mentioned.
I'm going to let you have the last word, but I want to tweak the question a little bit. I want to ask you specifically, does cost matter? Does safety matter in helping you choose Tessie over other immune checkpoint inhibitors? But is there anything else that would veer you towards using Tessie versus all the other immune checkpoint inhibitors in your clinic?
Yeah, cost and safety matters. It's important factors. The preclinical mechanism is nice to have. If it's the only factor, then it doesn't matter. But it's nice to have with equal, let's say, to be honest, with equal clinical activity, but trend towards favorable toxicity and cost. So we have the different arguments put together in a scientific, adequate way, I think.
So thank you very much for all of you for participating in this edition of the EIOC Journal Club. I think I had a thorough enjoyment of my time here today. I got to hear Eric and his thoughts with regards to upper GI malignancies and immune checkpoint inhibitors, and really integrating a new kid on the block in the form of tocilizumab for patients with upper GI malignancies. It's always good to have more options. It creates more competition. It reduces price. Price is a sensitive point that we all will agree does matter when you are actually treating your patients in the clinic. And for the first time, we've seen that there's also a better safety profile. I'm especially looking forward to a lot of the data that's going to come out in the future of the combination strategies that we're going to see for Tessie in combination with drugs like zanitumumab, and I cannot even pronounce that drug's name, or in combination with other targeted agents, which is all in the pipeline as we go along. So good options for our patients. You've all been fantastic, and I hope to see you at the next edition of the EIOC Journal Club. Thank you so much, and thank you again.
Thank you.
Thank you.
Thank you. Thank you.
Good night.
Bye-bye.
Thank you.